And our next speaker is Dr. Gary Monteiro, who is a colleague of mine at Houston Methodist. He did his anesthesiology training and medical school at VCU, which is a Virginia Commonwealth University in Richmond. He did his cardiac fellowship and adult cardiac fellowship in University of Washington in Seattle, and a PED CV anesthesia fellowship at Texas Children's Hospital. And his interests are adult congenital, obviously. He's our man for that. And he also has an interest in heart and lung transplantation and bloodless surgery. Thank you.
So welcome, everybody. It's really exciting to have a whole group of new fellows here. You picked the right fellowship. I'm sure you guys were between this and ambulatory. And so you guys in the future, you won't always just be doing cardiac, of course. You'll have a career where you're taking care of the sickest patients. When your colleagues in general anesthesia, OB, peds, whatever, when the patient's too sick for surgery, it's going to be your job, and it's exciting. Every single day you'll be taking care of somebody that's sicker than your colleagues want to take care of. But it's awesome. It's the best decision I've ever made. So I'm going to talk about coagulation management in the cardiac operating room. This is a passion of mine. My mentor when I was a resident was a coagulation cardiac anesthesiologist. That was his research. We did a lot of bloodless surgery when I was a resident. Then I went across the country, and I was shocked at how much we were transfusing patients. And then as I've moved around and been in different places, that the culture of the different place really influences transfusion and coagulation. And there's no consensus on any of this stuff. It's super interesting as you see regional variation. So I'm going to, in 15 minutes, teach you everything you need to know about coagulation management. I could literally talk for an hour on how to run an INR, but we're not going to do that. Oh, I would recommend, if you have a day off for your post-call, spending 15 minutes, an hour in the lab with your guys, wherever you are, running these tests. Because then you'll get it. Then you'll get why people are sending the wrong test when they're trying to figure something out. And they're making clinical decisions. They may have sent the wrong test, or the results don't make any sense. But if you spend a half day in the lab, your understanding of coagulation management is just going to explode. And I used to hang out in the lab, eat lunch in there, and run these lab tests with our guys. And I still go in there and do tags and rotems, and it's just super interesting to me. Okay. That didn't work. Okay, here it is, right? You guys memorized this for I guess you had to take that board exam, that basic thing. But we have cascades, and that's sort of the classic thing. We have an intrinsic and extrinsic and a common pathway, and this is how we were all taught this. There's some factors. There's amplification, platelets get involved, there's some injury, whatever. This really doesn't help you in the clinical setting, right? This is a framework that we all learned when we were doing hematology or whatever in our rotations. But we're just gonna frame some concepts around some patient cases. And I just sort of throw them together, they're collections. So patient one, just some elective patient for a 3-vessel cab. Patients on Brilinta. You guys are constantly going to be looking up the names of all these drugs that are coming out, what class they are, who's on who. Your different cardiologists will have different preferences to put people on different drugs in the same class. So this patient's on Brilinta, was told to not stop taking it by their cardiologist. They're in the pre-op area. Someone decides to send a pre-procedure TEG with the idea of just canceling the case if they see a lot of platelet inhibition, right? It's not what some of us would do, but this actually happened. Here's the TEG. Are you guys all familiar with TEGs? Or you've seen them, you're probably, So long story short, you put some blood in a cup. The cup spins. At some point, the clot starts to form between the little pin that's in the cup and the wall of the cup. This generates torque because the cup's rotating back and forth. Exact same concept as a rotem, except in rotem, guess what? The pin spins instead of the cup spinning. No big deal. So what we have here, as the clot starts to form, start of the test, clot starts to form, since the cup's going back and forth in two directions, it splits and goes up and down because it's just a torque vector. If it only went in one direction, it would only go up. But what do you notice about the TEG? Here are some reference numbers. Anything jump out at you as being abnormal? Looks okay, right? Sort of looks like a sausage. It looks okay. Maximum amplitude, if you're thinking clock strength, looks fine. This TEG doesn't give us any hint that there's any platelet inhibition, even though the patient's like wickedly loaded on Berlanta. Okay, so is the patient taking their Berlanta or not? So sort of a weird question because we completely sent the wrong test to test for it. A standard TEG's not going to show you platelet inhibition unless it's to a G2B 3A and the patient's not on one of those. Plavix doesn't show up, Berlanta doesn't show up, aspirin doesn't show up. So needless to say, the case went ahead. But there are modifications of these procedures where we can look at platelet inhibition, and we'll talk about those in a little bit. So this is an example right off the bat of somebody thinking, maybe we'll send a coagulation test to test some aspect of coagulation, but the wrong test was sent. And you'll see this continuously in your career. What should they have sent? Any ideas? So yeah, so you could do standard lab platelet function screening. So you could do platelet aggregometry or platelet flow cytometry, which in Virginia was only run on Thursday. So, but as we've moved ahead in time, there are point of care testing. We could have done platelet inhibition studies on the TEG, right? Takes a little while, requires all the TEG machines to be run simultaneously. But on the market, and I just pulled this slide from some Indian anesthesia journal, there's multiple things that we can do to test for platelet function. There's a platelet function analyzer, which is just a company makes this machine, can test for aspirin inhibition. Platelet Works is another one, clearly trade name. And you can test for all these three, the three different classes individually. TEG platelet mapping. Verify Now is a point of care testing. I don't know if you guys have ever used that. The cardiologists use it a lot to see if the patients respond to Plavix. If they don't, then they'll switch them to something like Berlanta or Prasugrel. Multi-plate, it's just a little plate that vibrates. So these are tests that can actually show you if there's platelet inhibition. So patient 1, we come off pump, uneventful case, whatever. Off pump protamines given, the ACT is 115, all this stuff is routine. Then the patient says, or the surgeon says, the field's still wet. And then you're sitting there listening and the suckers sound like they're sucking a lot of blood. And then the surgeon said there's no clot in the field, right? It's a pretty standard story. We've all heard this a million times. What do you want to do? Anyone? Come on. What was that? Oh, so you could just hit them with platelets, right? Because you sort of already know the scenario. So you could go ahead and give them platelets, super common, probably your most common deficit other than hemodilution after being on pump. You could send some labs, so let's see. We could just stay here and let's try that. Okay, so let's say, I think we skipped one. Okay, so let's say we sent some labs. The labs that you typically send in a cardiac operating room are here, right? Not exotic, right? You have your PT, INR, PTT, ACT we do all the time, fibrinogen, platelet count, various tests of platelet function, ROTEMs and TEGs. Factor levels, probably a little more exotic, right? But so, like I said, you guys are gonna learn a lot if you run these tests, right? You draw some tubes of blood, they're citrated for your PT, INR, goes to the lab, they spin it out. It's a test on plasma. You add some calcium to get over the citrate, right? PTT, we're gonna add some phospholipid to activate it. PT, we're gonna add cellulite or kaolin. And then we just watch the blood clot. That's how these tests work. You add an activator, and then you literally sit there and see if it clots. ACT is the exact same way, except it's whole blood. You put whole blood in a little tube or in a little thing, and then you literally sit there, and it gets kaolin or cellulite, and then you time it until it clots. Pretty archaic testing. Bleeding times was another one that was ridiculous. We used to just cut their arm and time them. I don't know if you guys ever did that. That was just a ridiculous test. Fibrinogen, we can look at fibrinogen numbers, like how much fibrinogen is there, but we can also look at fibrinogen function, which is really exciting because a lot of our patients have fibrinogens in the 300, but when we actually look at the function, it's not functioning that great. Platelet counts, platelet function testing, rotem tags, factor levels. So this patient got all that, whatever, they got a whole bunch of stuff sent. So here's our stuff. Patient's bleeding. INR is 1.7. Nobody gets excited about that. Platelet count's 220. We're not really worried about the count because we know the patient's got inhibition. Fibrinogen's fine. Hemoglobin's 8.9. Patient gets 3 rounds of platelets, some DDAVP, because, why not? And then 2 units of FFP. So in this patient, they end up getting, for their coagulopathy, with a hemoglobin of, let's call it 9, they end up getting a total volume of 1.4 liters to correct their coagulopathy. It corrects and they don't bleed. What's their hemoglobin when they get to the ICU? Yeah, it's 6.5. So they just bought themselves, depending on your intensivist, a transfusion. Is there a better way? Yeah, it depends on your institution, but this is totally normal. This is a totally fine scenario. This happens all the time, every day. Why do your patients bleed now? So what's the most common? And Berlanta's not the most common. We have patients coming all the time to the OR who are on antiplatelet medications. They're on anticoagulants. This is just your life. They're on heparin infusions that are getting shut off 1 hour before they come to the OR. They can have hereditary disorders of bleeding. They can have surgical, which this is very common for us, surgical reasons for bleeding. And it's typically, I always call it factor 14 when the surgeons ask me to transfuse and there's clearly a hole. Functional disorders where you have adequate, numbers of these things, but for some reason they're dysfunctional. So dysfibrinemia or dysfunctional platelets. And then probably the most common, other than platelets getting chewed up by the pump and beat up a little, is dilution, right? Remember, we don't really see deficits in coagulation until we lose 30% of our normal factor function, which is easy when we go on pump. If you give a couple liters here or there, you dilute out the patients. Smaller patients dilute more, dilution of platelets. So we're going to go into our next slide here in a second, or not. That's okay. Can you advance the slide? There we go. Okay, so we have a bunch of stuff from the blood bank. Of course, we have PRBCs. You get it from the blood bank. Sole role of PRBCs is what was discussed in the previous lecture, to increase hemoglobin, to increase oxygen carrying content in the blood, to increase oxygen delivery. We have FFP, which I just looked at the numbers for FFP. In the past year and a half, I've given 2 units of FFP in a couple hundred cases at this point. The reason I haven't been using it as much is if you look at the factor concentration in a unit of FFP, it's about 1 unit per ml. Most of this stuff is measured sort of on factor 9 levels. But you give 500 cc's of FFP, you're sort of giving 500 units of various of each individual factor. With some of the concentrates, 20 cc's is 500 units. So you're getting more bang for your buck with less hemodilution. Different talk. We'll sort of address it in a little bit. Cryoprecipitate's everybody's friend. You take some FFP, you cool it down, you thaw it, and it's the thick stuff. But it has fibrinogen, fibronectin. Everyone throws that in there. That's always a board question. Von Wille's factor, factor 13, and factor 8. Typically, we use cryoprecipitate for deficits of fibrinogen. And then, of course, platelets, everyone's best friend. So patient 2, a little more interesting. 65-year-old guy with a bicuspid aortic stenosis, and he's also got an ascending aneurysm. So very run-of-the-mill case for any of us. He's going to get his AVR done and his ascending done. Coincidentally, whenever you guys are doing bicuspid aortic stenosis, make sure you always look at the ascending aorta. You're always going to look at it, but rule out the phenomenon of post-stenotic dilation. Always do a complete exam. The crux is he's a Jehovah's Witness. So he's refusing the stuff on the previous slide from the blood bank. He doesn't want FFP. Certainly doesn't want PRBCs. He doesn't want cryo. He doesn't want anything from the blood bank. He will take albumin for some reason. Good biventricular function. He has a good starting hemoglobin and good platelets. Have you guys all done bloodless cardiac surgery at your previous institutions or been exposed to it? So, which leads us, when you have patients who refuse blood, you start thinking about what are all the stuff that they will accept, because you don't really care what they won't accept. I don't really care what the platelet count is because they're not going to take platelets. DDAVP as an adjunct. Conjugated estrogen used to be around before DDAVP, but I swear nobody uses that anymore. Factor concentrates are sort of was hot and, the sort of the hot topic. So there are a couple commercially available factor concentrates on the market. And they all have sexy little names, like Kcentra, Bebulin, and depends on your institution, whichever one you have. But it really comes down to just two things you need to think about. Factor concentrates in the United States are either called 3-factor or 4-factor concentrates. If it's a 4-factor, it has factor 7 in it. If it's a 3-factor, it doesn't have factor 7 in it. So they have 2, 7, 9, and 10. The US mainly approved for reversal of Coumadin. And then they can be activated or non-activated. Like, in our coagulation cascades, we have non-activated factors that by the step before them get converted to activated. And then, of course, there's straight factor 7, activated factor 7 concentrate, which is also available. The one that we use where I am is, just so you know the nomenclature, is a 4-factor non-activated. And it also has a trade name, which they don't pay me, so I'm not going to tell you. And then there's also fibrinogen concentrates, which are the non-blood bank analog to cryoprecipitate, right? So we have one available in the United States, but it's basically freeze-dried fibrinogen, and you mix it up and you get 1,000 or 1 gram of fibrinogen out of it, which is essentially the same thing as giving 10 to 20 of cryo. And then don't forget about your topicals. This is, like, to me, sort of the next level or the next place we're going with coagulation management. Thrombin sprays, we all have that now. The little patches we put on there, they're all different proprietary names. I think we're going to see a lot more glues and topical stuff for rapid control of bleeding. I think it's really sexy, and I think the adhesive companies are on this, and the medical engineers, and they're always playing with new adhesives. And it won't be that long before we see something where we inject something into the bloodstream while they're spraying something, where the two meet at clots. And I think that's going to be really exciting when that happens. Right now we're using, like, BioGlue, which if you've ever done a redo chest on somebody with BioGlue, it's a disaster. Because BioGlue is just albumin and glutaraldehyde, and then you squirt it all in the chest. And it just turns into a brick. But topicals. And then the other thing that just to reinforce here for a second is the simple stuff. You can have all your numbers in line. You give them awesome platelets. Their platelets are working. All their factors are awesome. Whatever. There's no holes in the aorta. They're hypothermic. They're going to bleed. Their acid base is off. They're going to bleed. They're hypocalcemic. As you guys all remember from hematology when you were med students, calcium's a cofactor. Hemodynamics, hypertensive patients are going to bleed more, right? You guys are nodding because you don't agree with me. This stuff is cheap. Like, warming a patient up is cheap. It doesn't cost anything. It's just not sexy and you don't think about it. Correcting acid base, correcting calcium. And then I threw this slide on here just so you guys will believe me. So it's hard to see, but here's 37 degrees. Here's 25 degrees. It's just PT, PTTs, and then thrombin time, which nobody does anymore. But you can see just as we get hypothermic, all of our sort of standard tests and our factor activity and factor amplification decreases, so our clotting times all go up. I mean, it's common sense, we all know that. And then this is a sexy slide right here, stolen from Google. And they just this is all based just on this top one where you have normal, INR's 1, right? And then they made the patient acidotic, changed nothing else. INR went to 1.5. They made the patient hypothermic, changed nothing at 1.5. Acidosis and hypothermia with no change in factor concentration or activation, 2.2. Dilution, 2.5. All three of these guys, 2.9. right? And you can ignore the cumin and stuff. So it does make a difference, but it's easy to deal with, right? We rewarm patients. You know, if you're sitting there, ask them to put a bear hugger on, ask them to warm the patient, maintain the temperature. Because temperature, pH, calcium, acidosis, these are cheap, but as you can tell from the slides, very, very effective stuff. And then the temperature slide, do you guys know what temperature coagulation tests are run in the lab? Like your patients, make us some number, they're 32 degrees, you send it off to the lab for your INR, your PTT. 37 degrees. Your ACT machine, when you're hypothermic, when you're on pump, if you look at it, there'll be a little flashing light that says heater. So all coagulation tests are run at 37 degrees. Well, coagulation tests where you're actually testing the clotting in the blood are tested at 37 degrees. So you always have to remember that in the back of your head. You can, oh, the INR is 1, but your patient's cold and they're bleeding. It's because the INR in the patient's actually a lot higher. So remember, coagulation tests are run at 37 degrees, but that's not necessarily the temperature of your patient. That's your ideal temperature of your patient. Okay. You guys are all psyched about this stuff, I can tell. And I think I have one more slide. When in doubt, go back on pump, okay? I actually made this during a case and was showing the surgeon. Remember, if all your numbers are good, your temperature is good, your acidosis is good, it's a surgical problem. And you guys are all gonna run into the wall where you're gonna have to convince your surgeon that the coagulation parameters and everything you've done and given is stone cold normal. And then they're gonna say, my surgery was perfect. And then the patient's gonna bleed. And then they're gonna go back on, or they're gonna re-open the chest, and they're not gonna find anything, even though they threw a couple sutures and something. And then you're gonna say, I don't know what it was. Maybe it was just time and they stopped bleeding. But if you guys correct the coagulation, all the simple stuff, it's surgical. And don't be, I mean, as fellows, you're not gonna put your foot down, but you have to put your foot down when you're attending, and you have to tell them, reopen the chest. And I guarantee you, they're gonna tell you, I didn't find anything bleeding, but they put some sutures in there, and it'll be fine. So, any questions, or we can wait till the end? Yeah. Okay. Well, all the faculty from the different institutions are here for you guys. I want you to know that we're really making this push to work with each other. If you guys have any interests that you want to contact me for, like I said, adult congenital is like what I really like, and lung transplants. If anything you want to talk about, let me know. We're around. We're excited, so.